Hi, I'm Donna Brown. I'm with the Florida Institute for Child Welfare, and today we're speaking with Dr. Shamra Studt, who is an assistant professor at the Florida State University College of Social Work. And this quarter, the Institute Insights is highlighting residential group homes, and Dr. Studt is Shamra?
You can call me Shamra, yeah, absolutely.
Okay. Shamra has done extensive research concerning child welfare involved youth placed in residential and group care facilities. So we're really so pleased that you're here to share your expertise with us.
And thank you for inviting me. I appreciate it.
And so the first question I have is, you have said that residential treatment is an intervention often reserved for youth with the greatest psychological needs and who are particularly high risk for experiencing poor developmental outcomes. What have you found to be the most promising practices for such vulnerable youth?
Well, it's kind of a complex answer to that question. First of all, based on the collection of characteristics of the youth that are served in residential programs, plus my own experience having worked for a number of years in residential care, we know that we have a pretty heterogeneous population. And there's a lot of evidence-supported treatments and even evidence-supported models of group care that have been shown to be effective at treating some of the symptoms that are common in the populations of kids that are treated in group care settings. That said, a lot of those studies, particularly with the evidence-supported treatments, they haven't specifically studied, so they're shown to be effective at treating the symptoms, but they haven't necessarily been studied and shown to be efficacious or effective for this particular population. Mm-hmm. And so research in this area, there just hasn't been a lot of research really devoted to cultivating an in-depth understanding of the types of youth that are served in residential settings. And so what it comes down to is, what's most important is being able to provide the right services, so matching the services to the needs of the youth. I keep going. And providing the right services at the right time, under the right conditions. And it's really not sufficient to say that we don't have enough information about the youth, and it's not sufficient enough information to say that, based on the research, we can say that youth served in residential tend to be those with, more severe behavioral health issues or, high service utilizers. We need to go on a little bit more than that in order to really determine what's effective for, this subset of the foster care population. So in the research, it's just not there yet. But, that said, there are some evidence-supported models of group care. So like Teaching Family Model probably has the strongest research base. And then there's others like the CARE model, which is out of Cornell University. So Martha Holden's developed and done some research on that model. Sanctuary, and there's a few others that have been shown to be effective. But if you look at kind of like the common elements of some of those more effective models, so what kind of starts to emerge would be models that have an implicit or explicit focus on relationship-based care, that provide structured supervision and developmentally targeted services. Mm-hmm. There's pretty good research basis supporting that when you provide family-based group care or you focus on family involvement, we see better outcomes, and there's a good emerging research base for the use of trauma-informed programming in residential settings. So if we had to kind of identify some effective practices at the moment, it might come down to those, but a lot of room for growth, particularly based on a better, more complete or holistic understanding of the types of youth that make up that population.
Mm-hmm. It's emerging,
It's emerging, but the research in group care, it was kind of, in child welfare, there's been a long-standing preference toward the least restrictive settings, and as a result, some of the research on residential, the investment wasn't there. We're focusing on other areas of the continuum, and so there's kind of a big period of lag in the research, and then we started to see, it's coming back a little bit. We'll kind of see how the Family First Prevention Services Act impacts that sort of momentum that was building in residential care research. So.
Yeah. Thank you. And your research has also examined the effectiveness, I know you mentioned, of trauma-informed models of residential treatment for youth. And I wondered, based on your findings, number one, does it indicate that you would recommend the use of trauma-informed models of care? And are trauma-informed models particularly important for youth in residential care?
Mm-hmm. So first, when you look at research that's compared samples of youth who are served in residential settings with those that are served in non-residential settings, so like family-based care, even community mental health, like outpatient services, some real differences emerge in those populations. And part of it is that we do have differences in terms of the types of youth that make up those who tend to go toward residential versus those non-residential settings. But it's also it's also related to where those kids are at on their kind of developmental or behavioral trajectory at the time that those placement decisions are made. So there is some overlap in the population. But that said, some of the differences that emerge from that research most consistently is we can see that the kids that are on the residential kind of placement path tend to exhibit more severe levels of functional impairment across multiple domains. And there's also a higher prevalence of exposure to complex trauma and prolonged exposure to traumatic experiences that's above and beyond what you tend to see in the general foster care population, which is generally highly traumatized already. So these kids are kind of standing out above and beyond that. So we have a highly trauma-affected population, and then with trauma-informed residential care, there's two core components at work, and one of them is providing trauma recovery treatment, and then the other is providing a therapeutic living environment. And so you have the treatment and the living environment that are operating from the same principles of care, ideally, right? And so the work that's going on in that therapeutic space is supported in the care environment. So when it works, it sets up a unique opportunity where a child, while they're working on their trauma recovery, that is, it's facilitated and it's supported in the care environment by sort of filtering them from some of the stressors that are part of the external environment outside of that treatment setting. So when it works, it can really maximize the effectiveness of that trauma-focused recovery treatment. So given that, I think, theoretically, it makes a lot of sense. It's a good fit because we've got a highly trauma-affected population, and we've got a model that's designed to respond to that and kind of create this sort of space that's grounded in providing, psychological and physical safety and reducing or minimizing exposure to potentially re-traumatizing incidents. But when you look at the research, I would have to say, from the standpoint of academia, it's still emerging. There's a lot of promising research out there that shows good results of trauma-informed programs, residential programs. And there's some different models out there, like Sanctuary is one of the more well-known ones, but there's others, the fairy tale model. So what I think my recommendation would be is on the basis of what we know about the population, the theoretical fit of those models with that population, and some of the promising research that's coming from studies of those models. There's, I think, a strong basis for supporting continued research in that area. And maybe what that could look like would be identifying among, those trauma-informed programs, what are the core elements of effective practice? And in particular, of those elements, identifying those that can be most readily adapted into the practice setting.
Yeah, and so, and from that, designing a new program.
Yeah, integrating it into, an existing program, so making it feasible to do that, because, there are the existing models, but they're just not always accessible to providers. They either, they maybe don't fit quite perfectly in their specific treatment context, or they just don't have the resources necessary to, to implement those models to fidelity in their settings.
Well, it does sound exciting as far as a possible way to help the children, the youth, to manage the trauma in their lives.
Yeah, I think it's exciting, it's promising, and we've certainly got policy supporting a movement toward that. So I would expect, and that's part of why I think in the research we need to be able to focus on, identifying what are those effective elements to make trauma-informed programming something that's within the reach of providers, of any provider, and then framing that in a way where we can operationalize it and measure that practice, so that we have a way of, programs not just saying we're trauma-informed, but we have a way to show that there's some fidelity, or that they're actually providing a trauma-informed model.
So I did read a co-authored an article. It's a review of current trends, research, and recommendations for strengthening the evidence base and quality of residential group care. And I would like you to share with us your recommendations for improving the quality of care.
Okay, so in that article, I mentioned 3 avenues toward improving the quality of care. And the first one was through licensing. State licensing criteria usually outlines kind of the minimum requirements that programs have to meet in order to be considered of having the capacity to provide, quality care, to keep children safe, to provide a good care setting for them. But those are the minimum thresholds. But I think that's the place to start. So like Florida requires licensing for all their residential programs, but not every state does. The other avenue would be through, in addition to licensing, accreditation. And so this is also, a good way to really have your program thoroughly evaluated. But the limitations of accreditation is that it's so intensive, it's time consuming, and it's expensive. So it's just not accessible to all providers. And it's, one set of accreditation standards is different from another. So we're also kind of being evaluated on different criteria. So it's not like there's a universal set of accreditation standards out there. But if programs, have the capacity to go through the accreditation process, I highly recommend it. I think it's worth their time to do it. And then the third avenue would be related to the work that we've been doing in Florida to establish a set of quality practice standards and performance measures for group homes. And so these both expand upon the requirements of licensing. So it goes beyond the minimum requirements, and it's grounded in research as well as best practice guidelines on, what we think are kind of those essential or core elements that need to be in place in order to provide high quality care above and beyond the minimum quality thresholds that are assessed through licensing. Okay. So we've kind of framed that, at least in Florida. This is one way to approach quality standards, but we've framed the quality standards we're working on and currently piloting throughout the state as a quality enhancement and taking that sort of orientation. And in Florida, they're implementing the quality standards assessment as part of the annual relicensure process. So in doing that, all programs across the state are being assessed on a universal set of practice standards. So it's kind of promoting this uptake of a universal set of research-based and best practice standards in the programs. It's making it accessible, so all providers are getting this quality evaluation of their programs, and it's speeding a process of continuous quality improvement because they're being assessed, annually, and they can use that information that comes out of that assessment to sort of see how they're doing in these different practice domains, like providing family and culturally informed services, the education, how are they doing there, and then the provider can use that to evaluate their model and make some decisions about, how they might improve their model.
Okay, so the enhancements are optional.
Yeah, they don't. So they are optional. In Florida, the programs, the group care providers have to meet the licensing standards in order to even participate in. First of all, to be licensed to provide care, but also it's kind of the prerequisite to being able to participate in quality standards assessment. And so, it's designed to really facilitate the providers adopting practices to help enhance the quality of care that they're providing. But we know that just by the fact that they're taking part in the assessment, that they're at least meeting those minimum quality requirements.
And does the state provide training and different ways in order to help a program enhance?
Well, right now, that's the idea. So right now we are just now piloting. So we've gone around the state and we've done trainings and webinars to teach and orient, everyone to providers, the CDC, the licensing teams who are the lead kind of implementation drivers on this, on how to complete the assessment.
Yeah.
So from there, it would go to after we've validated it, because we need to validate before we say, we want to make sure that these truly are the sets of standards that are connected with, a selected set of youth outcomes, right? And so once we get to that point, then the providers can start using that information to make decisions about quality improvement in their program, but it can also be used at more of an aggregated level. So the lead agencies in their regions might look at how their programs are performing and say, well, in this domain of assessment-driven services, we don't seem to be quite where we'd like them to be. And so is there something we can do to help facilitate that? That same kind of process could happen at the state level, led by the Department of Children and Families in partnerships with, other, institutes or agencies that could provide training, if they're not on certain areas, to help make sure that those resources are available that the providers can use to enhance their services. Yeah. So I think that's how we kind of see it working. The other opportunity, though, that I see in this is it could create sort of a peer learning network among the providers themselves, where if we find some select programs who are just doing really stellar in the area of family engagement, then they're doing something that the rest of the field could potentially benefit from. And if they can find a way to kind of do sort of a information exchange, if you will, then we can kind of elevate each other across the the network of group care providers can learn from one another and elevate practice together.
That's a wonderful idea. And I think with technology, those regional differences become less, of a barrier.
Yeah, they're not a big, yeah, absolutely. They could do something like this.
Exactly. Okay, so I am curious. You had mentioned this earlier about the Families First Prevention Service Act, and just how you feel it's going to affect residential care.
Yeah, I think the Family First Prevention Services Act presents both some opportunities and also it certainly could have some impacts and will have impacts on residential care. So, for instance, it's redefining residential in many ways as we know it, because the funding, the federal funding that's available, used to be available broadly, is now just available to a certain set of group homes that meet, that are either providing services geared toward youth who are at risk or being sex trafficked, for maternity homes, independent living, and a new category of residential, a program that's called a Qualified Residential Treatment Program. And if you compare the QRTP to kind of residential care as it exists now, it sort of sounds like it's kind of at the higher end, like a residential treatment facility. Mm-hmm. So I think, there are concerns that as we implement this in practice, it may end up reducing some of the available placements for group homes. There's also kind of this, group care as it exists, it's oftentimes talked about like it's one broad thing, but it's actually, just a service modality. And within that, there's a wide variety of models and services and approaches, and they range from, the highly structured sort of like residential treatment facilities that provide structure and clinical services for youth that are more on the severe end of the service continuum, right? But also within that modality are residential group care programs that look like, structured foster homes, essentially. And where you'd walk into the setting, you might not be able to immediately distinguish the difference. They're licensed differently, but they're not necessarily in practice, looking all that different. Sometimes one distinction is the kids in the residential group care setting may have access to more services. Mm-hmm. But in the day-to-day of it all, they look very, very similar to a group home. And they tend to be serving the kids on the lower end of the severity spectrum who aren't necessarily, a good fit for family foster care. Mm-hmm. So the evidence of that would be that, prior to their placement in that group care setting, there was, they've got a lot of failed foster care attempts to place them in foster care, and it's just not working. So they place them in a setting that has a little bit more structure, and we're able to stabilize them. And then ideally, we don't want to move them immediately. We want to be able to keep them stable for long enough that we can do some more work that helps them, improve their well-being and be, clearly on a pathway toward permanency. Mm-hmm. And so now with Family First Prevention, I guess my concern would be for kind of the kids that are in between, right? They're not necessarily doing particularly well in family foster care, and we're kind of seeing them bounce all over the place. But they don't quite need qualified residential care, and they don't necessarily meet criteria for any of those other placements, like, maternity care or independent living. And so I think states have a challenge on their hands in terms of figuring out how do we make sure that those sort of in-between kids have placements available to them that are going to meet their needs. And so, you know, I think as you look around the country, it's going to be very interesting to do some comparing to see how different states are responding. So, like Florida decided to delay to give themselves time to figure out how to best adapt to this.
Yes.
But there's other states like Nebraska and Kentucky who are moving forward with this. They're ready to implement actually as of now, right? Mm-hmm. And so, you know, give it a little bit of time, and I think it would be great if we could do some, you know, kind of looking across the states to see, you know, what approaches worked, maybe what were the consequences of different approaches. But I think that's the other piece of this legislation, that there isn't any language in there that builds in some requirements around evaluating the impacts of you know, these changes to group care. There's so I think in some ways it's a missed opportunity, because at some point I think there is a need for us to really devote our attention to focusing on this population of kids and figuring out what works for them, you know, and making sure that when we make sweeping policy change, they're not sort of just caught up in the mix and once again not really getting what they need.
Yes, because there are a lot of children in group care at present who would not fit any of the new options.
Right.
And so they're all going to have to find an alternative placement.
That's right. Yeah. So it'll, you know, it may require doing some kind of restructuring of group care, but within that language in the legislation does say that whatever approach that states take, it can't be something that leads to an increase in basically shifting the child welfare population, the kids who are served in group care, over to juvenile justice, right? Mm-hmm. Because that's happened in other countries where they tried to reduce and eliminate their group care. They just saw it, that, you know, the population shifted over there because the services weren't available in the child welfare system. And you know, and I think there's also language around not wanting to see an increase in placement instability. So I think that the states have a real challenge on their hands and how they're going to respond to this and meet those requirements.
Yes. And it sounds like you're going to play an important part of the transition.
We're going to be, so the Families First Prevention Services Act is, you know, it's happening, but it's not impacting the Quality Standards Initiative, which has been, it actually dates back to late 2014, but we've been working on this as a large team for a long time, and a lot of people have contributed to it. But it doesn't, you know, when it comes to services, you know, it's important, one, that we get the kids in the settings that are most suited to their needs, right? But even after that, if you don't have quality care, regardless of whether it's group care or foster care or even in-home care, you're not going to get positive outcomes. And so quality matters regardless of the legislation that's going on otherwise. So, you know, quality equals effective, more efficient care, which equals better youth outcomes. So, so we're moving forward with that, but also in the language of the Family First Act, there are a clear set of kind of guidelines or expectations for what the qualified residential treatment programs should look like. So trauma-informed, 24-hour nursing, access to nursing care, and several, you know, other ones. But as far as those other placements, like the maternity homes, independent living, the sex trafficking homes, there's really no requirements around that. They'll fund them, but it's just not held to the same level of criteria is the qualified residential programs. And so there is some need to continue to monitor quality, even in the qualified residential programs, because the standards do go beyond those criteria as well.
Oh, thank you. And this is the last question. It's really based on what you've been sharing, is suggestions that you would have for policymakers in Florida in light of the legislation. What would you recommend that they do?
Well, I would recommend that they make their decisions cautiously and in an informed way. So based on research, data, collecting data where we have gaps in our information that would be necessary to make informed decisions. You know, making sure you're hearing and building in opportunities to hear the concerns and ideas of the stakeholders. So that's residential providers, it's the lead contract agencies, it's of course the Florida Department of Children and Families, or in other states their child welfare entity.
Yeah.
It's the families and the youth, and then combining all of that to make decisions, and hopefully from a bipartisan place.
Yes.
So decisions that are in the best interest of the children and as grounded in evidence as possible.
Mm-hmm. Okay. And do you just feel that the legislation, the way it's written, has enough flexibility that the state can accomplish those things?
What things specifically?
That you had mentioned, like the outcomes for the children within a context of quality and data to inform that quality.
I think so. I mean, I think, yeah. Is there enough flexibility in terms of time to get that information?
Yeah.
I think it depends on the state and where they're at. But, states can opt for a 2-year delay.
Okay.
And is that sufficient time to respond to every, gap in this area? Absolutely not. But that is sufficient time to do some information gathering, mm-hmm. and to make an effort to try. And I see some states are actively doing that. This also kind of relates back to the role of the Quality Standards Initiative. So as part of that, so there's the Quality Standards Assessment, which is the main part of this. But what we're also doing with this assessment is gathering what will be a really pretty comprehensive index of all of the 309 plus group care facilities throughout the state. So looking at their models, the services they provide, the types of youth they're serving, and so on. And so that information can be used to help kind of, I think, get a sense of how restructuring our system might actually impact our available services given what it currently looks like. So we should have that information next spring.
Okay. You're working on a lot, and it's very exciting work. I think, as you had mentioned, the vulnerability of the youth that we're talking about, mm-hmm. the trauma that they've experienced. All of your work seems to be, coming at improving their lives, their outcomes, from all different perspectives. So that's
thank you. It's been quite a journey.
All right. Well, is there anything else you wanted to add, or?
I don't think. I appreciate this opportunity to talk with you and get to talk about the work and what I think is, an important issue. I think we have to decide as a system to invest in our most vulnerable children and families, and making sure that as we're making decisions about services that we're not failing to fully consider the implications across our service continuum, across the full population of kids. And I say this because I think this is kind of what's happened in the past. We've seen a pretty substantial neglect of research, but also investment in group care, and I think it's kind of it kind of shows. So, and the part of that, why that's important, of course, is because there's the continued need of those youth and those families. And so let's focus on them. Let's invest in them.
Yes. Yes. Well, thank you.
You're welcome.